Dear colleagues, welcome to this podcast. I'm Dr. Marija Buljan from Dermatovenerology Clinic in Zagreb, and on this occasion, I would like to discuss and offer an approach to patients with pigmented nail lesions. The assessment and management of pigmented nail lesions can be challenging for clinicians because differential diagnosis is broad and ranges from common self-limiting conditions such as subungual hematoma to potentially fatal conditions such as subungual melanoma. These lesions can therefore be divided into melanocytic and non-melanocytic, and they can also be categorized as neoplastic, traumatic, infective, systemic, drug-induced, and ethnic type pigmentation. The most intriguing clinical presentation of nail pigmentation is longitudinal melanonychia. This is a specific appearance of a linear pigmented band on a nail plate, which can result from the same variety of diagnoses mentioned before. Early subungual melanoma often presents as longitudinal melanonychia, and early recognition of this tumor is crucial, not only for survival, but if detected early enough, patients can be cured with a digit-sparing surgery which has significantly low impact on their quality of life. Assessment begins with a thorough history of the lesion. This includes noting the duration of nail pigmentation, changes over time, and previous trauma. However, it is important not to exclude a diagnosis of malignancy based on a history of trauma because many patients with nail melanoma will recall an injury to the digit. Just remember, the great Bob Marley died at the age of 36 from melanoma that started under his big toenail, and at the beginning it was misdiagnosed as a soccer injury. Clinical examination of nail pigmentation should begin with observation. The size, color, and distribution of nail discoloration should be observed, as well as possible spread to the periungual skin or nail dystrophy. Nail polish should be thoroughly removed from all nails so we can observe all nails. Therefore, having a bottle of acetone in your office might be a good idea. Dermoscopic observation of the nail unit can be performed with a handheld dermoscope or with a digital dermoscope, and gel should always be used as an interface medium due to thickness and convexity of the nail plate. Performing onychoscopy or dermatoscopy of nail unit includes dermoscopy of nail plate, free edge dermoscopy, dermoscopy of periungual skin, and if possible, performing intraoperative dermoscopy may be a useful guide for site of biopsy when needed. Free edge dermoscopy may be helpful in assessing the origin of the nail plate pigment. So, if the pigment is located on the upper portion of the free edge, then it is produced in the proximal matrix, and if the pigment is in the lower portion, its origin lies on the distal matrix. Performing free edge dermoscopy can reveal discrete spread of pigmentation into hyponychium area, like in this patient, where this was a reason to immediately perform nail matrix biopsy instead of digital follow-up, and this was a melanoma in situ. As it is reviewed in this very nice article, dermoscopy can give us useful information in analysis of pigmented nail lesions and help avoid unnecessary nail biopsies, which is an invasive procedure, as you can see in this image. In cases of melanonychia, it is important to establish whether the pigment is melanin or not, and to determine whether the pigmentation of melanin is due to activation or proliferation, and whether it is benign or malignant. Melanocytic pigmentations are usually brown to black, located within the nail plate, and have a longitudinal aspect. On the other hand, exogenous nail pigmentation has the color of the substance that adheres to the nail plate and does not always have a longitudinal distribution. Usually it is located near the nail folds or in the center of the nail plate, and the most common causes of non-melanocytic pigmentation are subungual hematoma, fungal melanonychia, and green nails due to Pseudomonas infection. Subungual hematoma is an important differential diagnosis of the nail melanoma when a longitudinal disposition of the hemorrhage is observed. So subungual hematoma on dermoscopy reveals homogeneous black, purple, and reddish to brown coloration, a well-limited rounded proximal edge, and peripheral clots and streaks. However, blood spot may be observed in cases of melanoma, hence their presence does not rule out the diagnosis. The lesion should be considered suspicious if the hemorrhage does not move with the plate growth or if it reappears at the same place. In this patient, we can observe splinter hemorrhage in the nail plate, but on the free edge dermoscopy, we can see some subungual papillomatous mass corresponding to onychopapilloma. In determining whether the pigmentation is due to melanocyte activation or proliferation, color is important. Gray bands are in favor of activation, whereas brown to black bands are in favor of melanocyte proliferation. Bands that are caused by activation are benign and do not require biopsy, so perform digital dermoscopy follow-up if newly developed. The number of digits involved is an important diagnostic clue. If more than one digit is affected, it is likely to be melanocytic activation, and it may be found in a variety of listed conditions, including Addison's disease, as it is in my patient shown in this slide. Here is otherwise healthy patient with darker skin type and ethnic type pigmentations as multiple melanonychia involving both hands and feet, as well as mucosal melanotic macules. And here is a patient with multiple melanonychia where melanocyte activation occurred as a result of chemotherapy. And a patient with melanonychia due to friction from shoes or due to pressure from one toe against another. So, when melanonychia is considered a melanocytic proliferation, the most important thing is to decide whether it is benign or malignant. Brown to grayish bands with regular pattern, including individual lines with similar shades of color, similar thickness, and regularly spaced and parallel, are a sign of benign proliferation, and such lesions can be monitored. Brown to black bands with an irregular pattern where lines vary in color, are irregularly spaced, have different thicknesses, and may cross each other, are suggestive of malignant proliferation, especially if they have triangular shape with wider proximal part. Such lesions warrant nail matrix biopsy. The Hutchinson and the micro-Hutchinson sign, as well as nail dystrophy and the greater extent of nail plate involvement, are all signs indicative of malignancy. Serial monitoring of a lesion can be a useful tool in the management of more subtle lesions. In this patient with a light brown 2 mm broad melanonychia on her fifth finger, we performed digital follow-up after 3 months and we noticed progression. Then we performed nail matrix biopsy and melanoma in situ was diagnosed. Accordingly, we then performed the extirpation of the entire nail unit and the defect was covered with a full thickness free skin flap taken from the left upper arm. Patient is in regular follow-up for 3 years and disease-free. So to conclude, onychoscopy is a very useful tool in analysis of pigmented nail lesions and it should be combined with thorough history and clinical observation. Histopathology is still the gold standard for the evaluation of atypical nail pigmentation, but dermoscopy can help avoid unnecessary nail biopsies and improve detection of an early nail matrix melanoma. Therefore, in patients with adulthood acquired monodactylic melanonychia with dermoscopic signs of atypia, nail matrix biopsy should be performed. And finally, I would like to emphasize that childhood melanocytic lesions are beyond the scope of this presentation due to the important differences from adult lesions in both clinical and dermoscopic as well as histopathological aspects. So with this, I thank you very much for your attention and I hope you enjoyed this podcast.